Good morning. Welcome and thank you for joining us for our Northern Light Health, Good Health is Good Business Zoom conference. Today marks our 66th session of this series since June of 2020. While it was born of the need to offer COVID-19 business management information and recommendations during the pandemic, it has evolved to include other healthcare issues both in the news and of importance to our business leader audience. Based on your feedback, after today's session, we will only update on COVID-19 when actionable items emerge. While COVID-19 is not front and center in the news, and most people have placed it in the rearview mirror, it is as dynamic as ever. Scientifically, it is fascinating. Pragmatically, much less so. Rest assured, Dr. Jarvis, me, and many other clinicians at Northern Light Health will stay abreast daily and keep you informed as needed. We'll start off today with a timely update on COVID-19, followed by an in-depth discussion on suicide prevention and response. We'll address the stigma of suicide, look at the risk factors and warning signs, consider the interaction between mental health and suicide, give you ways to start the conversation about suicide, what response strategies to consider, operationalizing crisis management, and provide you with useful resources. Lots to cover, so let's get started. Our panelists today are Greg Marley, Senior Clinical Director of Suicide Prevention at NOMI, Maine, the National Alliance on Mental Illness. Sheila Thibodeau, Director of Operations and an Employee Assistance Program Counselor and Trainer with Northern Light Workforce. Dr. Jim Jarvis, Senior Physician Executive at Northern Light Health and Director of Clinical Education at Northern Light Eastern Maine Medical Center. I'm Dr. Ed Gilkey, Senior Physician Executive at Northern Light Health. I'll be your moderator for the next hour. Before we get started, I will read our legal disclosure. The information presented in this session is provided for educational purposes only and is not meant to substitute professional or medical judgment. Northern Light Health does not know the particulars of your situation, so the information presented today is intended to be general in nature and may not apply to every individual situation. Northern Light Health and the presenters make no guarantees or warranties regarding any information provided. A reminder, this hour is for you. If at any time you have a question for our panelists, please use the Q&A function. I'll keep track of your questions and have our speakers respond. Also, I hope each of you will take a few minutes immediately following this hour to answer our quick 5-question survey. Your input directly affects our topics and helps guide our future conferences. Dr. Jarvis will start us off with the latest on COVID-19. Dr. Jarvis?
Thank you, Ed, and thank you, everybody that's listening. I'm going to just give a brief update on vaccinations that are recommended for this fall because they're ever changing and we have new information that just happened this week. First is the seasonal influenza or flu shot. It's recommended for everyone who's at 6 months of age or older. One of the things that's really important to know is that it appears to be a very good match for the expected strains in the United States. We talked about in this forum before about when we look at what our influenza season is going to be like here in the United States, we first look at the Southern Hemisphere because their flu season occurs before ours, and particularly with Australia, whose economy and makeup is similar to that we see here in the United States. And what they found was that the flu vaccine, the strains that are of influenza that were circulating in Australia recently are exactly the ones that we covered in our influenza vaccine for this year. Influenza or seasonal flu shots are available now, and they're available at many retail pharmacies and across Northern Light Health as well. So the next one is COVID-19 vaccine. You can see that I wrote seasonal with a question mark there. We are hopeful that we are now headed into a realm where we now just do seasonal COVID vaccines, much like we do with flu shots for influenza. Still a little bit early for us to tell, but that looks like the direction that we're headed. Just on Tuesday, both the Pfizer and Moderna messenger RNA vaccines were approved for use in the United States, and they got approval from the CDC at the federal level for distribution and administration. The Novavax vaccine, which we talked about in the past, is a more traditional type vaccine, may be delayed for a little while longer while they look for some more data and information. The vaccines are now recommended for everyone 6 months of age and older, similar to that of the flu shot. The good news about this particular vaccine is that it targets the current family of coronaviruses. Those are the things that cause COVID-19 that are circulating not just here in the United States, but around the world. They're all variants within that Omicron family, and specifically that subfamily of XBB. And specifically, this vaccine targets the XBB family. We hope that that will give very good protection through our winter months. These should be available next week because we just had that approval. For those of you who wonder, can I get my flu shot and my COVID shot at the same time? Yes, you can. And so that's important for people to know. There may need to be a little bit of a delay between the two if you decide to get them at different times. Here is another little tidbit here that for the messenger RNA vaccine, there was some data out there that says that if you get it in the same arm each time, you actually have a better immune response. So if you remember which arm you got your COVID vaccine shot in the last time, hey, try to get it in that same arm this time. Next slide, please. As Ed said, we've kind of transitioned in our thought, at least socially, around COVID. And I wanted to put this slide up here because I think it hammers home why it's so important that we need to still remain diligent and to consider vaccines. And what this slide was prepared by the CDC and talks about for children, and this is about children, where vaccines that we have been giving to individuals for some time now, and compares it to the time period of how many deaths occurred in that particular population prior to those routine vaccines happening. So if you just look at the bottom slide there, you can see that COVID-19 was far more deadly for children than most of those other things that we have been giving routine vaccinations to prevent deaths in children for many years. The time period that you see there is the time period that they looked at prior to those vaccines being readily available and recommended for children of that particular age category that they described there. But you can see that 6 months to 18 years of age, in just 2022 alone, we had many deaths occur in our pediatric population from COVID. And so that's the reason why the strong recommendation for everyone to get vaccinated, to one, protect themselves, but also to protect our communities. Next slide, please. And then there's just one other vaccine to talk about, and that's the one against respiratory syncytial virus, or RSV. Many people never even heard of RSV until last winter when we had a resurgence of RSV outbreaks across the country, resulting in lots of death. RSV typically just causes routine cold symptoms. It's one of the normal cold viruses that we talk about each year. But it can be severely impact the lives of people over the age of 60 and newborns. And that's the reason why there's a new vaccine out there. It's recommended for those people who are over age 60, but it comes with a caution that it should be discussed with their provider before getting that vaccine. So you won't see clinics set up just to give the RSV vaccine like we do for COVID and for influenza, because it does require a little bit of a discussion. And that has to do with a very rare side effect that can happen in some individuals around particularly an arrhythmia or a strange rhythm of the heart that can occur. And so they want that discussion to have. It's also recommended for women who are pregnant and are due to deliver during the RSV season. And that's because they will produce antibodies that get passed on to their child. And so their infant is protected for a period of time after birth from RSV. Unfortunately, this vaccine won't be available until late October at the earliest, so you can't get all three of the vaccines that I talked about at the same time. And it is unclear whether or not this will be a one-time thing where you get vaccinated and it gives you a long period of protection, or we'll have to make this a seasonal vaccine. I also put in a reminder here that for infants, there is an antibody against RSV that can be administered to help prevent infections. And that's something to talk about with your pediatrician or your family physician as to whether or not the age of the infant warrants them to have that particular vaccine. Again, people over the age of 60 and newborns are the most susceptible to RSV and have the higher rate of severe disease and death. And I believe that's all of my slides.
Well, thanks, Jim. And you'll be joining us at the Q&A part of the session today and available for questions on all those topics that you shared with us. So thanks, Jim. Next,
no worries. Thanks, Ed.
Sure. Next, our speaker is Greg Marley, who will share his wealth of knowledge and experience in suicide prevention. Greg? You're on mute, Greg. Okay, thank you.
Happy to be here and happy to join in this conversation. Suicide Prevention Month is September, and one of the ground pieces we always focus on is suicide is something we need to be capable and willing to talk about, because that's how we prevent it. So what we're going to cover, we're going to start out like we always do, addressing some of all of this is around stigma, and that may change as people are more comfortable, if they get language and knowledge to talk about it. And recognize also that within a business setting, and certainly within a healthcare setting, the power dynamics may make it more challenging for someone to come forward and ask for help or to seek that support. Always think about what else may be at play here in your setting. Next, please. So the first thing we need to do in order to become a power of talking about and preventing suicide is to learn the language that fits well, not only within our mouth, but is appropriate to use. If you're talking about a loss that is a death that was self-inflicted and seemed to be intentional, we rule that. That's formally called a suicide. So you might talk about someone who dies by suicide or dies of suicide. And if someone makes an attempt on their life and lives, you call it a suicide attempt. But you can always say they tried to end their life, they tried to kill themselves, and if someone dies, you may say they took their own life. I ask you, please, don't use the phrase commit or a successful suicide, or don't refer to an attempt where someone lives as a failed suicide or a failed attempt. It's just the wrong use of those words, success and failure. And we are trying to edge the phrase committed suicide gently out of our language. It's really something that families are very sensitive of. For you, in your role, just be clear, direct in your use of language that is appropriate for the age, the stage, and the setting for who you're talking with. So I'm going to just touch on some facts that kind of push against some of the myths we might develop around suicide, particularly since it is quite stigmatized. There's that fear that if you talk openly and ask someone about suicide, you may plant that idea in their mind. And what we know, talking it openly creates an opportunity for someone who's struggling to say, oh, help does exist. I can get help. Asking about suicide, talking about it is exactly what needs to happen. And people are concerned that if someone has become suicidal, they'll always be suicidal. And what we know for the vast majority of people who go through a crisis around suicide, it's short and it passes. And we count on that. And if we intervene to try and stop that suicide, most people move on and do not die by suicide. Prevention works. And we work with that with the idea that most people who are suicidal are also ambivalent. They may be struggling to end the pain that they're feeling, but they're also seeking a way to reconnect with help. And so support, treatment, intervention does help and helps them through that dark time. And we know that most of the people who are really struggling talk to at least someone before they take action toward ending their life. They're just going through the crisis, and we need to support them to get to the other side. And in that sense, make sure you're always addressing any conversation or mention of suicide risk very seriously. Connect the person with help. So why might people hesitate to ask? And I'm going to invite you we can go ahead and populate this whole slide. Recognize that, for many people, they're afraid to need help, and they're afraid what might happen if they talk about wanting to die. They may be afraid to upset and anger others. That whole shame, the fear, the stigma comes up. And some people who are younger or struggling with depression, they may also struggle to describe what they're feeling. And in that same place, they may feel that they're beyond help. And for youth, be aware, even for adults, they may prefer to initially confide in their peers rather than reach out to that helping adult And our job is to make sure that the doorways are open, that they know that you're available to connect them with help. So the other question we may have is why people might hesitate to help. Next slide. What would hold them back from intervening? And huge around here is that feeling of inadequacy. You know, what if I'm wrong? What if I don't say the right thing? What if I make it worse? Some people say, well, this is not my job, and they feel someone else will pick this up, that bystander effect. The most important piece here, the most important piece, make sure you do something. It's less important exactly what you do, but if you're concerned about someone, reach in, ask, show that concern, do something. Next. And I want to acknowledge how common suicide is. And we often see the headlines about deaths by homicide. We don't see them about suicide. But we lose someone in this country approximately every 11 minutes, more than 49,000 people in the most recent year. It's the 10th leading cause of death in this country. It's the second leading cause for young people. And our suicide deaths are about twice as common as deaths by homicides nationally, and much higher rates in Maine, as we'll see. Men still die by suicide, male-identified people, about 4 times more frequently than females. And we do need to pay attention to veteran rates of suicide. They're higher than the general population, and Maine has the 3rd highest proportional population of veterans of any state in the country. And we get closer to Maine. In 2022, we had about 251 suicide deaths in Maine, which is a reduction from recent years, but it's the second leading cause of death for young people up to age 35. And here we have more than 12 times more suicides than homicides. I often see people shock around that. It reflects 2 things. We have a higher rate of suicide than the national average, and we certainly live in a state that is much safer from violent crime. But every 36 hours, we lose someone to suicide in Maine. About every 10 days, that's a young person under the age of 25. And this is a very busy graph. This shows the rates of suicide in the population from 2000 through 2020. For the top line is Maine, the middle line, the blue line, is the United States as a whole, and the lower line is all of the Northeast, including New England and New York and New Jersey and Pennsylvania. And you can see most years, Maine is about 15% higher than the national average, and the highest in the Northeast. And what causes that? You know, we are an enormously rural state. We are the most rural state in the country when measured by the proportion of our people who live outside of an urban area. And with rurality comes challenging to access social supports, challenge to access professional supports. Part of rural living across this country is ease of access to firearms. The other things that go along for Maine include a higher rate of Caucasians, the widest state in the country. And Caucasians have a higher rate of suicide than any other ethnic group other than Native Americans, and that still drops below Caucasians around age 45. Our rates of substance use certainly adds to it as well. Next, please. So if you think about how do you identify someone who could be at greater risk for suicide? And since about year 2000, we've been addressing this as a population approach using the same elements that we do in any kind of education to address their needs around any major problem. We look at people who may have risk factors based on their situations, their status, their history, that statistically includes the risk of suicide, that raises the risk of suicide. Likely everyone on this call has some risk factors for suicide, but they're not predictive. And we hope everybody with those risk factors has some protective factors that increase resilience, that help balance out those risks. And we're going to focus more heavily toward the end of this section on warning signs. And warning signs represent those early changes in behavior that are observable, particularly observable in someone you know. So with risk factors, we get them from our family, way we were raised, family history. We get them from our personal life, our own history of health and mental health, our own style of addressing stress, our coping strategies. And we also get them from the environment, from our social setting, from the larger environment of our state and our culture. And let's talk about some of the risk factors for adults. Next, please. These are just some examples that I want to bring forward. And have a personal history of a suicide attempt is among the most predictive for future risk. Having a family history of suicide attempts also raises risk. Any significant mental health disorder, particularly one where there has been no recovery. We focus a lot on major mood disorders like depression and bipolar. We also look at heightened anxiety, particularly those that really interfere with a person's daily functioning. Any kind of trauma-based disorder like post-traumatic stress disorder. And those, particularly psychosis that's untreated, and also factor in eating disorders. Eating disorders have a high risk of suicide. Beyond that, since none of us are simple beings, look at mental health with comorbid substance use that's going on the same time, particularly substance use without recovery, and physical illness, particularly chronic illness with chronic pain, or those that are progressive, debilitating illnesses. And we also look at someone's trauma history, because that can raise their risk. Beyond that, we've learned so much over the past decade or two about significant insomnia and its impact on a person's ability to process emotions and stress in their life, and increasing the risk of suicide. In healthcare settings, we may also look, or you can hear that in someone's language, any loss of fear or loss of fear of pain or loss of fear of death. And there's plenty of other risk factors, but these are the ones I want to bring forward today. But I do want to go a little bit deeper in mental illness. We know from studies across the world, after a suicide death, approximately 90% of the people who died were diagnosable with some form of mental illness. And about 40% of them currently we're finding are in treatment of some form or recently have been in treatment. Next. And the highest above that is mood disorders. What we know from the violent death reporting system here in Maine and New England, the data we were generating from that over the past 5 years is that some of the most common situations for someone who has died by suicide is a mental health problem, particularly a depressed mood, particularly for people under the age of 65. And for older adults, that can be overshadowed by physical health concerns. But depressed mood is still a problem within that group. And if we're thinking about, particularly across the lifespan, how do we build protective factors? Because recognize protective factors can be built over time, not overnight, but there's something that we can build, and workplace settings can have a lot to do with that. And I'm going to focus on, within a workplace, what can build protective factors? That sense of I belong here. I'm known here, I'm accepted here, I'm liked here, I have friends here, I'm accepted is huge. The skills to do our jobs effectively, the skills to communicate and do problem solving, also the skills to manage stress, anger, deadlines, that kind of thing. Anything that increases our sense of purpose, that we matter in the world. That certainly include work and that work-life balance that we've been struggling with certainly over the past 3 years. But that sense of hope in future, hope in my life. Certainly, there are personal characteristics that can increase the protective factors, and not so much religious beliefs, but being part of a religious community that I am known by and feel congruent with. That's a strong protective factor. Obviously, safe environments, safe from physical harm, as well as safe emotionally. I'm accepted here for who I am. And any kind of support. In fact, the strongest protective factors are supportive people in my life who know me, who I know, who I can rely on. Those can be coworkers, friends, family, and access to the basic needs to meet my needs: healthcare, food, all those essential needs. Think about the protective factors in your setting and how you build them. And I want to remind you, we're going to talk about warning signs, and these are the things that you can notice as changes in somebody, particularly where you already have a baseline, we already know them. And in a work setting, we learn our coworkers. We learn their lives, their transitions over time. We celebrate them with them, as well as we recognize the hard times and the losses. So at a national level, we've looked at warning signs in a couple of levels. At the highest level, next, is clear signs of a suicidal crisis. And this is a constellation of things, these three pieces. So someone who's talking about suicide, threatening to harm themselves, and threats can be verbal, they can be in writing, they can be in text. And somebody who has got a plan, what they're going to do, and they may be seeking the means and to intend to carry out that plan. And the last piece, most of the time, and this can change with someone who's very much older, but they also typically show signs of distress. It can be anger, commonly agitation, restlessness, anxiety. They can't sit with this distress. And if those signs are together, boy, you need to take immediate action to connect them with help. Call a crisis line. If they bolt, this is the grounds to call 911, because that is a level under which someone can be taken into protective custody to keep them safe. Don't leave them alone. Other warning signs are not so clear. Other than this top one, this is one we got from the federal government, but it was developed by a consensus group about 20 years ago now, but it's still so appropriate. So other than ideation, someone talking about suicide, the rest of these, in someone you know, they're going to get your attention. And they're going to invite you to step in and find out what's going on. So increased excessive substance abuse as a change. Statements that say, I don't matter anymore. My family would be better off if I wasn't here. I'm just a problem. Increase in agitation and anxiety that drives impulsivity. I'm leaving insomnia separate because that's really important, but it's somewhat separate. If someone is unable to sleep, only getting 1 or 2 hours a night, that's a crisis. Someone feeling trapped, and there are so many ways of feeling I'm trapped, I can't find my way out of this painful situation. A sense of hopelessness, nothing will ever change. Isolation, and that can include isolation at work, skipping work. Anger that's a change in keeping people at arm's length. Any kind of recklessness that says it doesn't matter if I live or die. And note those changes in mood. Again, these are invitations. Next. So those invitations can include statements that you're responding to. They can changes in behavior. And I'm adding to this also changes in hygiene, how they're showing up, what they're wearing, do they care what they look like anymore? And changes in the mood. And all of these, remember, they're inviting you to say, what's going on? I'm worried about you. Are you doing okay? You step forward rather than step back. Next, please. So from the point of view, from the mindset of someone who's struggling in a suicidal crisis, that crisis point means that their ability to cope with what's going on is overwhelmed, and they're in pain. And all pain is processed the same way in our brain: physical pain, emotional pain, spiritual pain, and that feels unbearable. And within that place of unbearable pain and crisis, they get to a place of all or nothing thinking, that they can't think their way out of the situation, and it feels like the only way to end the pain is to end their lives. What we count on, however, most of the time, there's that sense of ambivalence. They're in pain, but they're looking for a way out. They're looking for help. They're looking to connect with somebody or something. And that is going to lead them to communicate. Now, they may not communicate cleanly and artfully. It may be an outburst. It may be a burst into tears. And who they're likely to reach out toward is whoever they're most comfortable with. So those invitations are extended to who feels safe. And let's talk about what that might look like. In this case, a response, we're talking about a simple response to connect someone with the help they need. And that almost invariably starts with a conversation. And within that conversation, your attitude, how you reach in and connect with the person, is at least as important as your skills. So you say, how can I help? And that is what is in your whole being. You're going to invite the conversation, you're going to invite the story, and you're going to listen. And if it ever enters your mind that they may be suicidal, you're going to ask, and you're going to act to keep them safe, connect them with the next level of help. No cowgirls and no cowboys. So we do this together, and you're going to follow up with them after that crisis. The next time you see them, no matter what happens, you're going to say, hey, how you doing? So good to see you back. Can we connect you with further resources? And what you avoid, monitor your own gut and your own anxiety. Make sure you're not using judgmental or patronizing language or tones. And never, ever promise to keep a secret where safety is concerned. You say, hey, who else can we involve in this? So think about that within your role. And we have been using this very elegant and simple 3-step intervention in Maine for about 20 years. And the first is when you step in and say, hey, I'm concerned about you. How are you? You show you care. You listen. And again, if that ever enters your mind that suicide might be in their mind, you ask. And you ask it in a very clean, direct way. So how often have you considered ending your life? Have you been thinking about suicide? I'm worried about you. And if you use what I call the suicide-like question, if you ask, are they thinking of hurting themselves? Take the next step. Are you thinking of hurting yourself or ending your life? And if the answer you get back is yes, or sometimes, or maybe, then you're actively acting to get them help. You say, I'm going to stay with you until we connect you with somebody else. And let's talk about who we can call. Do you know about the crisis line? Don't leave them alone, because you are the warm handoff. And I'm going to let Sheila talk about crisis more, but I'm just going to say, call early and call often. But I want to do a couple of other slides before Sheila starts. So when there has been a suicidal crisis, that's what connects people with help. And many of us may not be willing to reach out to help until a crisis occurs. And when that crisis happens, and they get the help they need, it's recognizing when they come back to work, come back to their daily life, they're going to feel, oh man, I'm a little bit tender here. I'm afraid people might not respect me anymore. So what can you do in those moments? Offer hope. Always offer hope that things get better. Always follow up, ask if they're getting the help they need, and if not, how we can support that. Show your support. Collaborative work with them. Work with them to get a safety plan on how they manage well at work, what other people need to know, what they're willing to share. Help them to be able to know where they can get support at work and how they might get support through EAP or outside of work. And still, if suicidality is there, make sure that you connect with a crisis system to get them help immediately. And this is an area around suicide. Unless you know the person well, always err on the side of caution. And remember, the last piece of this, most of the time, as I said before, someone in a suicidal crisis is looking to end the pain they feel. And they're looking for help to stay alive. And we know through data all over the world, suicide is mostly a preventable tragedy. And our job is to impart hope and to reinforce that help is there and we can help them connect with it. That's suicide prevention. So we're going to skip this and I'm going to turn it over to Sheila to talk about how to get help.
Thanks, Greg. I could listen to you all day long. So, yep, you're right. Sheila Thibodeau is up next, and she'll look at this from the employee support perspective. Sheila?
Thank you, Dr. Gilkey, and thank you, Greg, for all of that information, critically important information. So next slide, please. There are many different suicide prevention and emotional support resources for those who may be struggling with suicide. The 988 Suicide and Crisis Lifeline offers 24/7 phone and text access to trained crisis counselors who can help people experiencing suicidal ideation, substance use, a mental health crisis, or any other kind of emotional distress. People can also call 988 if they're worried about a loved one or if a loved one may need support as well. An online chat function is available at 988lifeline.org. So while we just learned around a lot about fear and stigma, while there's a lot of fear and stigma around getting support, sometimes just sitting with an employee and calling or accessing these resources together can be helpful. It's important, though, to remember that it's really up to the employee. Another resource is the Intentional Warm Line. It's available toll-free from anywhere in Maine, 24 hours a day, 7 days a week. It's a mental health peer-to-peer phone support line for adults 18 and older, and this offers mutual conversations with a trained peer specialist who has life experience with mental health recovery. So the focus is to really encourage and foster recovery, moving toward wellness and reconnecting with the community. Also, there's NAMI Maine Helpline, and this is a referral line that offers mental health resources, information, and support. It's available Monday through Friday, 8 a.m. to 4 p.m. And this resource helps individuals find a service or a provider based on need, location, insurance type, and income. They offer resources and materials about mental health and recovery and engage in collaborative problem solving around mental health concerns. If there's an imminent threat or safety concern, employers should consider a wellness check. A welfare check, also known as a wellness check, is when law enforcement stops by a person's home just to check to make sure they're okay. Law enforcement will do welfare checks on behalf of lots of folks, concerned friends, loved ones, acquaintances, a coworker, a supervisor. You know, wellness checks were once associated with the elderly, but recently it's become a critical tool for the safety of diverse age groups. So with the rise in suicide rates, law enforcement are doing welfare checks more and more often for those who are at risk of taking their own lives. You can request a welfare check by either calling 911 or a non-emergency law enforcement line in your area. So some examples of when you might use this resource is if there has been a consistent lack of contact from an employee, maybe they've expressed that they're in a mental health crisis, or if you're aware of a verbalized plan with intent to harm self or others. This could be in person, this could be on the phone, in text, social media. These all could justify a welfare check. Always contact your EAP and HR department as well for guidance and recommendations in these types of situations. Next slide, please. Thank you. How businesses and leaders respond to the death of an employee by suicide is critical and sets the tone for the future of the work environment. So first, it's important that leadership respond compassionately and appropriately. A good place to start is to collaborate with HR and create a plan that allows employees to grieve and return to work to move forward as a team. Effectively leading a team through a complex process like the death by suicide builds trust and makes employees feel seen and supported. Responding insensitively, underwhelmingly, or overreacting can create a lot of distrust among employees. Inadequate leadership responses can leave employees feeling that their company is ill-equipped to handle the unimaginable, but really real challenges that they face in their personal lives. Leadership should be ready to show compassion and empathy to employees impacted by their coworker's death. So the initial shock of such a loss can really make productivity difficult for those bereaved by suicide. Provide all staff with information about hotlines for suicide prevention. Should another member be vulnerable to suicide ideation, this would give them immediate support. So this kind of information is critically important. Lighten workday duties and adjust expectations of bereaved employees to reduce additional stress. For example, sometimes we may just need to go home if that's possible. Offer bereavement leaves to attend the funeral and memorial services. In addition, leaders should allow time and space during the workday to talk to team members as a group and individually. And contact your EAP as soon as you are aware of the death and plan a critical incident response. I really would like to expand on this. I can't express enough the importance of offering this type of response. This typically occurs within 24 to 72 hours, and it offers a group and an individual support session. What we know is that through experience and through research, that gaining the appropriate support at the right time will yield the best results for employees to move through traumatic events. And talking this through with your EAP as soon as you know about the event can be helpful to set the stage for what's appropriate for your particular company. Don't sensationalize the suicide. Instead, be sensitive about the manner of death without skirting the topic or over dramatizing it. Don't focus on the details or the methods taken. Instead, focus on processing grief, appropriately commemorating the deceased, and again, educating staff about what to do in a mental health crisis and what support services they have available to them. We all have different reactions and emotions to suicide. There's not a one-size-fits-all way that individuals process it. Just because we think we know how someone will react doesn't mean we're correct. It's important to allow employees to commemorate their late coworker, but don't force them to do so. So for example, rather than creating something permanent at the workplace that will remind folks of the employee, employees can come together and they can decide, do they want to donate to a cause that was important to the deceased? Do they want to organize a group volunteer day to participate in suicide prevention efforts in the local community? Do they want to do something at work that reminds them of their coworker? Or maybe they'll think of something totally different that we hadn't even thought about. But the key is to listen, to offer support, and to respond based on whatever information that we're learning from our coworkers. Thank you.
Well, thanks, Sheila. Now we will have all our panelists join on video for questions. Sheila, these first questions are for you. How does someone engage with crisis via text? Do they text the number 1888 568-1112 or a different number?
Yeah, yes, they can reach it by that. And there are also, when you look at out on the line, you can find numbers specifically for the text. But yes, you can reach the text through that number.
Okay, so that's a viable option.
Mhm.
Follow up. In a practical sense, what does a wellness check by police look like?
Yeah, so what happens typically, my experience has been the police are contacted or law enforcement would be contacted, and they go through some questions and ensure that there's an agreement about does this reach the level for them to go out and respond. We have to provide certain information to them. If we're calling, we obviously feel that way, and they're great at responding, and they will take down information about the person, their where they're located, any kind of information they need to connect with them, and they will drive to their to wherever they're at and check on them and ask some questions and determine at that point. Are they okay? Do they need to take another step? Do they need to get additional services? Do they need to go to the emergency room? But typically it's communication with the law enforcement, providing enough information so that they know where to go, and then they do a basic assessment when they get there.
Great. Well, thanks for that, Sheila. Greg, we have a couple questions for you. How
Okay.
do you how do you do the warm handoff without sounding like you're passing the person off as someone else's problem? Great question.
Well, I think the cleanest way for most people to do that is to acknowledge I don't have all the knowledge and the resources to address all your needs, but I'm not about to leave you alone until we connect you with someone, and I'm going to be here when you come back. It's just that recognition, this is bigger than you and I. And who else? And I always suggest you're going to be working with the individual who's struggling so that they have some choices about who they're connecting with, but you're absolutely going to make sure you are actively connecting them with help.
Great, thanks. So, Greg, here's an astute statement by one of our participants for your comment. I don't know if this would fall under symptoms of depression, but I think some people also feel unworthy of help.
And certainly that would fall under the symptoms of depression. Often someone who's depressed blames themselves. Not only, and I mentioned that they may feel beyond hope, but they may also feel unworthy of help. And so then, and then that's, depression, we've learned you can intervene from the outside. They can hear the voices of people who they already trust that may push against that feelings of unworthiness. So you're going to be reassuring the person, you matter to me and you matter to us. And that's why I'm really trying to working with you to try and get the help you need. You matter.
So there's a follow-up question here that's consistent with what you just shared with us. How do you help someone who doesn't want help or doesn't think they need help?
I gotta
I
say,
saw that was a tough one.
that's the hardest. And I don't know how many times I've dealt with that or worked with individuals who are struggling with that. You can't, there is a point under which if someone is in imminent risk of harm, that wellness check can trigger someone being taken into custody to be assessed. We can't force someone to get help. And family members struggle with that, but it's from that place of I'm concerned about you. I care. You matter to me. You matter to this family. You matter to us, and we would be devastated to lose you. That's so you're using that personal connection, but we cannot force someone to get help. At some level, they may reach a place where we can involuntarily commit them into treatment. We have that right under the law, but trying to connect with someone around why it's important for them and why they matter can be effective.
I'll just share a little anecdotal story with everyone. During my first month in practice as a family physician in a rural part of Pennsylvania, patient came into my office and I knew within a few minutes that the diagnosis was acute bronchitis and what I was going to do. But consistent with my training, I asked, was there anything else you wanted to talk about today? And he said, well, doc, Before I came up here, I was sitting on my sofa with a gun in my mouth. And I was new to that community, so my network of resources was somewhat limited. But 5 hours later, I did have him committed. And I believe the fact that he was alive 5 years later perhaps helped save his life amongst other people. But along the way, he was very demanding that I do nothing about it because it would ruin his life, that he would lose his job, all sorts of bad things would happen. So it took an awful lot of internal strength to be able to get that. But these folks really do need help, and we have to find ways to get it. So a couple of more fast and furious questions as we're winding down our time. Greg, this looks like for you. How do you distinguish the younger folks' tendency to talk casually or joke about suicide versus someone who's using humor to deflect from a serious problem? Wow, that's complicated too.
And what we've done, and we certainly work a whole lot with school staff around just that question. And what we strongly invite them to do is every time they hear that language used, it's an invitation to check in with that student. To say, hey, I just heard you say from a frustrated voice that you may as well kill yourself. And so I'm wondering, what do you mean by that? And you say, well, they may say, well, I'm just saying I'm frustrated. You say, well, I can tell you, every time you use language like that, you and I are going to have a conversation, and because I'm going to check in because I worry about you. And we do that every time, because there have been kids who do those, what seems to be that statement of out of frustration, but underneath there is real suicidality. And I often reassure people, if they're doing this every day or every other day, and it always triggers, they're talking with you briefly, it means they are seeking a connection. They're seeking a connection with you, and your attending to them has meaning for them. Where there's smoke, there can be fire.
So Greg, this question requires a full day seminar. You have 30 seconds. How is requested euthanasia viewed?
Well, we have a law that was passed in Maine a few years ago, 2019, called Maine's Death with Dignity Law, which enables someone who is in a terminal state of illness and in their right mind without coercion to apply to a physician. And there's a waiting period and a process, and they can get the medication to end their lives. That is different than euthanasia, but sometimes people refer to that as requested euthanasia. And it's a process that it took Maine 9 times through the legislature before it was passed. It's still quite controversial. There's about 14 states that do it. But more than anything else, it also opens up that conversation for someone who is struggling toward the end of their life. Is there other ways to support you? Because we all want choices.
Yeah, true. So here's a comment to share with everyone. Northern Light Acadia has mental health liaisons that work with the Bangor Police Department. They are not in uniform and can be a great resource, particularly when individuals are leery of law enforcement. So thanks for that additional resource from one of our participants. And then Sheila, this question's for you, and we'll be sensitive once again to time. When an employee has been lost by suicide, how should HR get involved with the coworkers and help them with their grief? Be proactive or wait for employees to come forward needing help with their grief?
I strongly recommend that we're proactive. We don't force anything on folks, but we're definitely proactive. It was what I mentioned a bit ago about what we know that is most helpful is to offer some group and individual sessions, and just ensure that no one is mandated to do anything, but it does give employees an opportunity to get different kinds of services that feel most appropriate to them. Not a lot of people will raise their hand and say, oh, I would like to have some group support services right now. I will tell you, when we have done these kinds of services, and remember, there's a time frame. You don't want to do it too soon. People will still be in shock. You don't want to do it too late. They'll have already processed and maybe not gained the supports through that process. So if done within the protocol that we know helps best, it can be really helpful for folks. And inevitably, employees say, wow, I'm really glad that I did that. So critically important to set things in place, have a plan in place, not force people to do it, but make sure that they can be assessed at that time. And it also gives folks an opportunity to, do they need something more in the future?
Well, thanks, Sheila. So, oh boy, we have reached the end of our scheduled time, and once again, we could go on for another hour. We've included resources for you at the end of this presentation. Thank you all for joining us, and thank you to our panelists for such rich information. I hope this hour will help you to successfully manage your business. Just a reminder, we will be emailing you a survey right after our conference. Please be sure to give us your feedback so we can continue to provide relevant information.